Welcome to this video. As I cut to the bottom line, I'm not going to hide my disappointment. It seems that convalescent plasma, which is a treatment we'd had fairly high hopes for, is not clinically effective. Now, the idea behind convalescent plasma is you take someone who is recovering from the disease, from COVID-19, someone who is recovering, they have antibodies in their blood that fight the virus. And you give that plasma containing those antibodies to someone who is currently fighting the acute disease. It makes perfect sense. This is called passive immunity. It's a very well established principle. It works really well in babies. So when you were first born, virtually pretty well all of the antibodies in your mother's blood, they went across the plasma, they went across the placental membrane. There was transplacental, that's the word I was looking for, transplacental transfer of these antibodies into your neonatal blood. And that gave you passive immunity for the first few months of your life while you made your own active immunity. So the theory is really good, but it needed to be tested, and on clinical testing it doesn't seem to work very well. So that's the bottom line. If you want to skip this video, you can do. It's a bit of a disappointing therapeutic. There are glimmers of hope, and the implications of the bad news are pretty restrictive, I think. But let's look at it in some more detail now. If you want to stay with it, do stay with it. It's interesting. It really helps our understanding of immunity. It helps our understanding of how the body responds to viruses. It gives all sorts of useful background information. So do stick around. So this was a study, convalescent plasma in the management of moderate COVID-19 in adults in India. So these were all over 18 years of age. Open label, so the doctors and the patients knew whether they were getting the plasma or not. But it was a controlled trial. It is peer reviewed. It is published in the British Medical Journal the 12th of October. And I've actually read this in a bit of detail this morning. I kind of got into it. And it is a very well conducted study. And statistically, it seems to me, perfectly conducted. They took all the right statistical advice and they got some pretty hard data out of this. So I'm overall pretty pleased with this as a piece of science. So India, 39 public and private hospitals, 464 adults admitted with confirmed moderate COVID-19. So this was confirmed by laboratory diagnosis of the SARS coronavirus 2, so they were definitely positive. And these patients were actually moderately ill, that they were sort of what you might call typical hospital patients. And of course, we know the problem with patients admitted to hospital is they can deteriorate and require intensive care, and they can die, assuming intensive care is available, of course, which in the Indian situation it is not necessarily always available. So remarkably important to stop these patients deteriorating. Now, they had a respiratory rate of more than 24 a minute. Now, we normally say that normal breathing is about 12 to 20 per minute. And what one breath is, one breath in and one breath out, that counts as one respiration. And you can easily count this in anyone in your family. Just look at the chest rise and fall, or especially if they're lying flat, you can look at the tummy rising and falling as well. So it's one in, one out. Above 20 we would say is a tachypnea, a fast breathing. So these adults these patients were already somewhat tachypneic. They were breathing more quickly. And their oxygen saturations were down. We would expect the oxygen saturations to be about 96 or 97 or 98. These had 93. So they already had a level of what we would call hypoxemia. The levels of oxygen in the blood were somewhat low, not drastically low, but potentially on their way down. So these are the patients they selected, and they were randomised. It's so important in any clinical trial to randomise. That patients are allocated to the experimental group to receive the new treatment, or to the control group not to receive the new treatment on a randomised basis. Otherwise we have human subjectivity and the results just fly out the window. So this was done. So the convalescent plasma group, the group who got the convalescent plasma, 235, the intervention group. The other group were given the best standard care, as were the intervention group as well, of course. The control group, 229. So a reasonable size. And the reason that they stopped with this number of patients was they'd taken statistical advice that said that this would give them good statistical results. And it made the size of the trial manageable. So I'm accepting this as a reasonably good clinical trial. Obviously, you'd always like to see larger numbers, always, but it's the practicality of that. Now, the intervention group received 2 doses of 200 ml of convalescent plasma, and this plasma did have detectable neutralising antibodies in it. Now, remember, the neutralising antibodies are the antibodies that bind onto the spike protein of the virus and stop it going into the cell where the virus would infect that cell and would reproduce. We've looked at that quite a few times. But the levels of neutralising antibodies, of course, varied because this is a human product. Some patients would have more antibodies than others. Who were the donors? More on that later. But that was recognised. But the detecting neutralising antibodies were present. Now, the outcome measures. They wanted to look at progression to severe disease, all causes of death at 28 days and time to symptom resolution. All makes perfect sense. And of course, what we want is all these things to be good. We want no progression to severe disease. We want no one to die at 28 days. And we want the time to symptom resolution to be as short as possible. Now, the intervention group. Progression to severe disease, 44 patients, that's 19%. Mortality within the 28 days, 34 patients, that's 15%. Progression to severe disease, 17. Now, of course, this information is all very interesting but completely useless without the control group, who, remember, received the same treatment apart from not getting the plasma. So how did they do in comparison? Well, we already know, don't we, because I've given you the bottom line. Progression to severe disease in the intervention group, 44 and 19%. In the control group, it was 41, which is 18%. Not a statistical difference. So 44 patients as opposed to 41 patients, 19% as opposed to 18%. Basically, there was no difference. So the same number progressed to severe disease. Mortality within 28 days, 34 in the intervention group, 34 participants, that's 15%. In the control group, 31, okay, it's slightly not as good, 14%, but this is not a statistical difference. Progression to severe disease in the intervention group, 17, progression to severe disease in the control group, 17%, so we can see that by these major outcomes, statistically, there was no difference between the groups. The intervention was having no clinical effect, or no statistically significant clinical effect. It's a null result. It's just not working. So there you go. The results disappointing. Other things the same. Both groups needed the same duration of respiratory support, whether that was oxygenation or mechanical ventilation. Proportion receiving invasive mechanical ventilation was the same in both groups. Resolution of fever and cough was the same. Oxygen requirement was the same. Organ failure assessment was the same. We know, for example, that as well as the lungs failing, the heart can fail and the kidneys can fail. Again, that was the same in both groups. No difference between the two groups, unfortunately. WHO scale. This is an ordinal scale for clinical improvement. Same. Average levels of inflammatory markers. The same. Lactate, C-reactive protein, D-dimer, all these biochemical parameters the same. Now, the lactate indicates poor levels of circulation, because when there's not enough oxygen getting to tissues, the metabolism changes from aerobic metabolism to anaerobic metabolism, and the anaerobic metabolism causes the production of lactic acid. So if the levels of lactic acid are getting higher, it means the shock is progressing, the circulation is deteriorating, but the levels of lactate in both groups were the same. The C-reactive protein is an inflammatory marker, indicating the overall amount of inflammation in the body. That was the same. And the D-dimer. Now, what the D-dimer is when blood clots, and we know intravascular coagulation is a problem in this condition, especially in poorly people, that the blood can clot in the vessels. When the blood clots in the vessels, the fibrinogen in the blood, the soluble fibrinogen, changes into sticky strands of fibrin. But over hours and days, the body will break that fibrin down, and the degradation product of the fibrin is the D-dimer. So in other words, when the D-dimer is high, there's more blood clots in the circulation, more clotted blood in the circulation, which of course you don't want. But the D-dimer was the same in both groups, indicating the level of intravascular coagulation in both groups was the same. Neutralising antibody titers in plasma recipients did not correlate with clinical outcomes. So I did mention at the start of this that they were able to measure different levels of neutralising antibodies in different units of donated plasma, as you would expect. But they recorded this, and what they found is that the patients who had higher levels of neutralising antibodies in the plasma they received did not do better than the patients who had lower levels of neutralising antibodies in the plasma they received. This is surprising, but this is the nature of science. Doesn't matter how elegant your theory, doesn't matter how beautiful your imagination, doesn't matter what posh university you're sitting in, doesn't matter how big your office is as you theorise, none of that matters. You can have the best theory in the world. If it doesn't work in practice, it's wrong. This is the nature of empirical science, and it didn't make a difference. I'm surprised, but it didn't. Didn't make a difference. Now, was anything better in the intervention group who received the plasma? Or yes. The subjective feelings of the resolution of shortness of breath and fatigue at day 7 were better. And the patients, more patients who'd received the plasma tested antigen negative at 7 days. They were the only positive outcomes. But these did not affect the clinical course of the disease. Now, of course, it's better for the patient to feel better at day 7, but it didn't affect their longer term outcome. And quite frankly, whether the patient tests antigen negative or not at 7 days, I don't think matters too much to the patient. It probably prevents infection spreading to those around them, which is good, but this is not enough. Most doctors would not consider this enough to merit the antibody, the plasma therapy, the convalescent plasma therapy, given that the clinical course of the outcome is not altered. And what we need is we need to modify the clinical course of the illness, and that was not happening. Now, another observation, interesting, among the 38 patients who received ventilation, only 2 survived until day 28. In other words, 36 of them died. So 36 out of 38 unfortunately died. And we know that once patients are on mechanical ventilation, that is often not a good prognosis in COVID-19 infection. So what's the conclusion here? Convalescent plasma was not associated with reduction in progression to severe COVID-19 or all-cause mortality. No good, didn't work. Now, the authors say this has high generalizability, which means this study can be applied to other centres, other areas. And they do say that it approximates to convalescent plasma in real-life settings. So what the researchers are saying here, and bear in mind this is published in British Medical Journal, is this is probably going to be true in other settings. So, but there is a bit of hope. Let's just finish off. Don't just take what I say. Look up the reference for yourself, and don't just say what the writers of one paper say. Always compare that to other experts. But to be fair, this is roughly consistent with other convalescent plasma studies that have been done. They have not showed a great beneficial effect, unfortunately. But to take an outside expert opinion, Professor Ian Jones, Professor of Virology, Reading University, the poor performance of convalescent plasma in the trial is disappointing but not entirely surprising. Interesting. Now, why wasn't Professor Jones prized? Because he understands that it's the first days of this illness where the virus is causing the illness. And the people that get severely sick are the ones where the viral load is probably already down, but the inflammatory effects of the virus are already increasing. So by the time someone is deteriorating, by the time their oxygen levels have gone down, by the time their respiratory rate has gone up, that probably means they're over the worst infectious phase of the illness and are into the inflammatory phase of the illness, and it's the body's inflammatory immunological reaction which seems to be killing most people. So what the professor is saying here is no point bolting the stable door after the horse has already bolted, because these people were suffering more from the inflammatory than from the infectious part. So that's why he wasn't surprised, because of course these patients were already hospitalised, which means they'd probably been symptomatic for a few days before they'd been hospitalised. So he's not entirely surprised, and I understand that. I understand why he's not entirely surprised. Plasma more likely to work if given very early, he says, very early, which makes sense when there's still plenty of viruses around. Before the we want to get rid of the viruses before the viruses have got time to initiate the inflammatory reaction, which causes the severe pathology. So it makes perfect sense. Researchers should continue to conduct trials, but in newly diagnosed patients, getting them as early as possible is the key while it's still the virus. But the problem is, many people get the virus. So basically, what we're saying is that the convalescent plasma should work if it's given early enough. But of course, many people get the virus. Not all go on to develop complications. So what we would need here is some predictive tool that allows us to say, well, okay, this person's in the very early phase of the illness. Are they going to progress to severe illness? Now, if they were going to progress to severe illness, then give them the convalescent plasma at an early stage. If they were not going to progress on to severe illness, they were going to be minimally symptomatic or even asymptomatic, then you don't need to give them the convalescent plasma, which is always going to be in relatively short supply. There's never going to be a great abundance of this stuff because it's got to be taken from convalescent patients by definition. So, and the problem is, of course, we don't know always who's going to develop the more severe disease. We could selectively give it to patients with higher comorbidities with increasing age, but it would be better to have some predictor at an early stage of how severe the disease was likely to be. Then we could target this intervention more precisely, but unfortunately, as far as I'm aware, as we speak now, we don't have such a predictive tool. We can only predict probabilities of people becoming severely ill based on our understanding of age and comorbidities. So if this predictive tool came along, the convalescent plasma could be highly effective. Until then, a bit disappointing, really. Now, this is the professor again. We still don't have enough treatments for the early stage of disease to prevent severe disease and avoid this becoming an option. And until this becomes an option, avoiding being infected with the virus remains the key message. So basically what he's saying is that we can't predict it at an early stage. So don't get the infection in the first place. So that's fairly obvious. But it's worth saying because he is a professor of virology, so he's allowed to state the obvious. Now, implications of... So basically we're saying this treatment doesn't work, and we don't yet have the early diagnostic facilities to make it work effectively. Disappointing. Now, what are the implications of this for other therapies? Now, remember Donald Trump was given this monoclonal antibody therapy. So he was given these antibodies, these immunoglobulins, but these have been synthetically produced in a lab. Well, they're not synthetically produced. They're not produced like a chemical. They're produced by living cells because they're antibodies. And he was given 2 of these, and that did seem to have a dramatic effect in one case. We can say nothing about the generalizability of that. So does this mean that the monoclonal antibody therapy will not work? Well, I actually don't think it does. I think the trials of this should continue because this can be given in a controlled dose at a higher dose. And when this is widely available, we could give this to more people at an early stage, therefore by preventing more people deteriorating. So I don't think this has got big implications for the monoclonal antibody treatments. I think this is a different thing. Long-term immunity, does it mean people won't have long-term immunity? Again, I don't think so because that's largely the lymphocytes, the memory lymphocytes that we've talked about, the memory T cells and the memory B cells. The T cells that will directly kill virally infected cells, the B cells that will make the antibodies. So I don't think it's got applications for that, and I'm not worried about the applications of this in regards to vaccine. I still think the vaccines are going to work, again because of the numerous immunological effects that vaccines have, as well as the simple antibody thing. And anyway, we don't know that the antibody thing won't work, because if you are vaccinated, we don't know that monoclonal antibodies treatment won't work because that's not fully investigated. But the vaccines, the point about the vaccine is you give the vaccine before someone is sick. So they make the antibodies in the immune cells within the week or two after they've been vaccinated. Then if they become subsequently infected, and they have the antibodies, they'll have the antibodies there ready to tackle the virus at the earlier stage of the person's infection. So it would be like giving convalescent plasma the day before they showed symptoms, or the day after they developed symptoms. The antibodies will be already in place. So I don't think it has any implications for vaccination. But still, we were hopeful for a while that this was going to work, that therapeutics for COVID-19 illness were still struggling for the antiviral treatments. We're good at treating the inflammation with the steroids. Not so good, in fact quite bad really, at killing the virus at an early stage with therapeutic interventions. Watch this space though, lots of people working on it. Thank you for watching this video if you stayed. Thank you for watching as always.